So I guess before we even get into the genomics or our approach specifically to gynecologic cancer, it's worth taking a step back and just discussing briefly the kind of institutional initiatives around this that allow this work to happen. As everyone here knows, genomic testing for somatic mutations in gynecologic cancer is actually not a standard of care for any of the gynecologic cancers. And as a result of that, there's a kind of a priori barrier to doing this type of testing. And at an institutional level, this was recognized, and there was philanthropic funds put into place to do this type of testing with the kind of goal of bringing this testing to patients regardless of whether this is the clinical standard of care and really a billable test to patients. And this has obviously been a tremendous luxury for the institution to be able to order this testing regardless of whether insurance companies will pay. And they set an ambitious goal of sequencing about 12,000 tumors this way a year, and recognized the only tumors when this slide was made that this was considered standard were these 5 tumor types here. We also recognized that in order for this test to be useful for many of the gynecologic cancers and other cancers, simply looking at base substitutions or simple mutations wouldn't be enough, but we need to look at all classes of mutations. And this was a test that was developed by Mike Berger and Mark Ladani and others, great collaboration between bioinformatics and pathology. And this is a test that is spiritually quite similar to the Foundation Medicine test that probably everyone here is familiar with. And the real big point here is that it not only looks at base substitutions, but looks at other classes of genomic alterations, including small indels, which are typically missed by other sequencing methodologies like Sanger sequencing, copy number alterations, and select rearrangements. The other point being is that this is a very highly multiplexed test and relatively cost efficient. So this test is able to look at 410 genes in tumor normal pairs. Each gene is sequenced on average 600 times or greater. And the total cost of this test, because it can be multiplexed across multiple patients in one run, is about $800 to $1,000 is the true cost of us running this test. This is the list of genes. It's quite comprehensive. And this has resulted in this slide is a little bit old now, but a tremendous almost exponential increase in the number of genes that we're sequencing. This is, old testing. We used to do about 4,000 cases a year, but this was mainly done on a sequenome-based test where we were looking for select mutations in about 8 genes. But as we've expanded to broader panels, we're sequencing actually millions of genes across tens of thousands of patients. We recognized that this created a data problem for us in terms of sorting through the data, assigning clinical trials to patients. And we were lucky enough to have tremendous help from our innovations and our IT groups here to incorporate this genomic data into an already rich institutional database, which had been created over many, many years. And what that looks like is we have an institutional database that pulls from a number of canonical data sources at the institution. One of them, obviously critically important, is surgical pathology. What does the patient have? What is their diagnosis? The electronic medical records, so we can look at not only structured data like laboratory tests, but we could even try to do natural language processing on scan reports, on physician notes. This also has access to billing records. This is the test, we call it MSK-IMPACT, so the actual genomic data is put into the institutional database, and actually it's an even richer data set than is printed in the reports. They have the ability to actually look for alterations even more specifically than the printed static report can. And also patient scheduling. One of the things that we learned as we did this type of work early on is that when you get this data on patients, they may not need it right then. They may, for example, you might get testing, you may find a mutation that you want to action on, but the patient is in remission or the patient is on chemotherapy. And so giving the PIs of the studies that we run the ability to track patients as they flow through the Sloan Kettering system, as they have a CAT scan, as they have a physician visit, was very important. And this can generate automatic alerts to physicians. It also feeds into something we call the CBio portal, which it was responsible for a lot of the figures that Dr. Levine just showed. And it's become a very rich resource for the institution to visualize the data that we're generating and plan new clinical trials. Changing gears slightly, this is work that's been done by a dedicated team. We call the Onco KB team here, led by Nikki Schultz. And this is to try to bring some order to the mutations that we see and classifying them based on what we think the level of evidence is in terms of guiding treatment decisions. Level 1 is fairly straightforward. I think there's wide agreement on this. This is FDA-approved therapy in the FDA-approved indication. So this would be use of a BRAF inhibitor in a BRAF mutant melanoma or use of an EGFR inhibitor in lung cancer. Obviously, we don't have any level 1 alterations in gynecologic cancer, with the exception being germline BRCA mutations for a PARP inhibitor. But this classification has been more really thought about conceptually for somatic mutations. Level 2A mutations, this is the category we've come up with again. There isn't necessarily standard agreement on this, but level 2A we've termed mutations that are already FDA-approved biomarkers, but not in the disease for which they were approved. So the example would be a BRAF V600 mutation in a non-melanoma cancer, or an EGFR missense mutation or exon 20 insertion in a non-lung cancer. Level 2B is really the same. This was split by NCCN level. And then level 3 are alterations that there is clinical data demonstrating that the mutation is associated with response to the agent in that disease. And then level 4 is kind of more tenuous preclinical associations. This was a slide that was not made by me. It was made by Tara, one of our excellent fellows. And this was applying this classification scheme to the data that we've generated through this testing. And what she did, which I think is really great, is juxtapose this to melanoma, a disease that does have level 1 alterations. So what you see with melanoma is that in this series, and I think this is actually slightly skewed by the testing that was ordered at the time of melanoma, about 25% had level 1 alterations. We would actually expect this number to be even higher, probably 50 or 60%, having to do with the rate of BRAF mutation in melanoma. So you can see across the board there are no level 1s in cervical cancer, uterine leiomyosarcoma, endometrial cancer, ovarian cancer. And you can see in ovarian cancer there are about 20% level 3s and barely any level 2s. This shifts slightly by disease. So endometrial cancer has a richer array of level 3 alterations, actually in excess of 40%. So because I can't talk about every disease in 15 minutes, I thought I would just use an anecdote to how we've approached matching patients with gynecologic cancer to targeted therapy and kind of dive into endometrial cancer a little bit. Just to give you one point I want to make about the data that's generated in patient by medical oncologists setting this type of test is a little bit different than the TCGA data, which is all patients who have primary surgeries, a great proportion of which in the endometrial series were surgically cured. And so there are differences, which I'm not really going to get into in great detail, but suffice to say there are differences in what we see in our metastatic population that are not entirely unexpected versus what the TCGA saw in other efforts that look primarily at primary surgical specimens. And what I'm not showing you here is that a very high proportion of this testing is actually done in metastatic specimens. And this just gives you a sense of the mixture of histologies. This is a statistic that we're fairly proud of, showing that 28% of our patients were subsequently enrolled to a clinical study that was matched to the result of their genomic testing, which may seem like a low number, but in the published literature, there have been several reports now of about 4 to 5% matching rates. So actually, we're doing a bit better than that. And this is what the data look like. This is actually somewhat old. This is back from February. We've sequenced a significantly larger number of cases since then. And what I've done is highlighted some of the mutations that we would consider to be potentially class 3 or above mutations. Some of these might be a slight stretch, like ARID1A, although there's emerging literature around that, and MYC as well. But certainly I think the others would classify as at least 3 or above. And I just wanted to focus on AKT as the kind of anecdote of this talk. But just to kind of spend a little bit more time on this, you can see patterns emerging clearly by histology. So for example, ERBB2 alterations are much more common in endometrial cancers, almost never seen actually in the serous, in our series here, which is slightly different than the reported literature, which reports ERBB2 amplification in about 25% of serous cancers, endometrial serous cancers. Obviously, the PIK3CA mutations are known to be present. PIK3R1 were actually even more prevalent in our series. I'm sorry, I'm getting it slightly off. PIK3CA were more prevalent and PIK3R1 less, but in a non-overlapping pattern largely. So diving into AKT, this is a gene that I've been very interested in. The most common mutation in AKT is E17K. This is a mutation that we know a lot about. There was a paper in 2006 in Nature describing this as an oncogene that is sufficient to transform cells. And what I've shown you here, which may not be completely apparent, is that the scale here cuts at 7. So all these are mutations that are seen less than 7 times versus AKT that's been seen over 100 times. And this is in a database of about 40,000 tumors across multiple tumor types. And so really, E17K is almost the completely predominant mutation in AKT1. The other one that you occasionally see is the Q79, which you see at about 10-fold lesser frequency. And then everything else is maybe 100-fold less common than even E17K. And when you look at the endometrioid cancers in our population, it turns out that about 15% of them have AKT1 E17K mutations. And actually now, this is again from February, when we look out further, the rate's risen to 20%. And in addition to these patients, which were all E17K, we've actually found 2 Q79 patients as well. And with the exception of this one hypermutated tumor, these have all been mutually exclusive to PIK3CA and PTEN, RAS, and other known drivers. And interestingly, they've all occurred in P53 wild-type tumors, primarily grade 1 or 2 endometrioid. So I think I've said most of those here. When you look at AKT1 mutations, or AKT1 E17K mutations across tumor types now, what you see is that breast cancer has a reported rate of about 2%. Bladder cancer, which always rises to the top of these lists, has a similar rate. Then you have colorectal, prostate, some cervical cancer cases, and then nothing else kind of sticks out at above 1%. One of the things that is notable is that endometrial cancer is actually missing from this list. And the reason is the TCGA actually didn't find any E17K mutations in the, 250 or so cases that were sequenced. So I'm not sure exactly why that is. Maybe the endometrioid cases, grade 1 or 2, there just weren't enough. And I think this is one of the things that we all recognize as people who manage gynecologic cancers, is that there are so many subtypes, and that each of these subtypes may have its own unique kind of genetic pattern. So although overall the rate of AKT1 mutation may only be 2% in endometrial cancers, it may be 20% in this subtype of endometrial cancer. I think we all recognize it from a practical level. It is hard to get drugs and trials for alterations that are present in 2% of your population, or even 20% of an extremely rare population. And so our way of getting access to patients where we find these alterations has been largely through, or these rare alterations, is largely through these basket studies, which enroll patients not by the tumor type that they have, but by the mutation they share in common. And this is kind of a simplified schema showing patients where the dots represent mutations that are shared across these tumor types. And this was actually the schema of the first basket study we did in BRAF, and these were actually the cohorts we chose to study and ultimately published. The core concepts of basket studies I've kind of outlined here. Multiple disease-specific cohorts, each with their own independent statistical analysis, and this kind of allows us to enroll patients regardless of their histology, but if we enroll sufficient numbers, to look at how the efficacy may differ based on the histologic background that the patients have. We typically have focused these studies where the alteration is rare. So if the alteration is present in 20 or 30% of your population, you don't need a basket study to study it. You can do a disease-specific study. But when it goes less than 5%, typically you just cannot conduct studies in a disease-specific fashion in such a rare population, except if the disease is incredibly common, like lung cancer. And even then, it creates challenges. Patients are treated uniformly. Whenever we've done these studies, we always had a cohort for patients that we didn't know were likely to even harbor the alteration. So for example, when we did this study, we didn't know about a number of rare hematologic cancers that harbored RAF mutations at very high frequencies. But even though we didn't know about them when the study was written, they were able to enroll in large numbers in the study. Kind of central to this entire effort is it assumes that matching patients to therapy is superior to unmatched therapy. That's implicit in this study design. And I've advocated strongly for use of local molecular screening with retrospective central confirmation as opposed to a central screening approach where the tumors are all sent to be screened by some multiplex assay. I think that creates logistical barriers, although I guess that remains to be seen. One of the things that we've been pleased with as we've done these studies is it started to garner regulatory support. So this was an article in the New York Times profiling one of our patients who had one of those rare hematologic cancers harboring a RAF mutation, who was enrolled on the basket study and is now 3 years into a complete remission. And this profiled another patient with a glioblastoma who 2 years later is also in a complete remission and also has a RAF mutation. And Richard Pazder, as you know, is the head of oncologics for the FDA, actually said explicitly that they would be willing to approve drugs based on basket study, given that these are essentially genetically orphan diseases, and actually said if a newer drug has a response rate of 50 to 60%, does it make sense to do a randomized study, who would go on that trial? So it was actually an acknowledgement that these are potentially could lead to new treatment options for patients. I've already alluded to most of these points, but as we think about designing studies that incorporate gynecologic cancer patients, just a couple of issues that are specific to our patient population. I've already alluded to the assay has to detect copy number alterations or things besides missense mutations, because in, for example, serous ovarian cancer, you almost never see missense mutations other than P53. We've thought about using other response criteria for patients with gynecologic cancer because they won't all have RECIST measurable disease. And a number of our studies now allow these patients, if they could be followed by other criteria such as CA125 or by PET scan, onto the study. And also you have to think about the comorbidities that are present in the populations you treat. For example, if you exclude all patients with diabetes, then you may not be able to enroll many patients with endometrial cancer onto your PI3 kinase inhibitor study. So diving into the relevance of the AKT E17K, kind of returning to that for a minute, this was a study that we participated in, a phase 1 study of AZD5363, which is a catalytic AKT inhibitor. And this was a patient treated in Japan with endometrioid ovarian cancer, but nonetheless endometrioid histology that harbored the E17K mutation. And you could see that almost a year out from therapy, the patient had an ongoing partial response to therapy that actually wound up lasting over a year. And this was presented at AACR, and it led to this. The study was amended to essentially incorporate a basket study into the original phase 1 study. And this is now the only part of the study that continues to enroll. And we chose two cohorts that have the highest rate of AKT mutation. One was ER-positive breast, another is gynecologic cancers, and then there was this other solid tumor that I referenced. And we started to, with a goal of enrolling 20 to each, doing an interim efficacy analysis and potentially expanding, with the idea that even this could be registrational data. And we've actually enrolled 40 or 50 patients as of this week on this study. So we've actually filled the breast cohort. We're about to fill the gynecologic cohort, and this cohort's lagging a little bit behind, but is close to filling. And the data is actually going to be presented shortly, November 7th at AACR. And I think it's pretty exciting. So this is obviously part of a very big effort. I just want to thank all these people. And we've basically tried to take the approach that I've outlined for AKT for each mutation that's relevant for gynecologic cancer and build a portfolio so we could treat a large number of our patients. So thank you.